Hello, everyone, and welcome to June Motherhood's Talking Points webinar series, designed to help busy prenatal healthcare providers stay up to date on relevant and pressing topics in prenatal and postpartum education. Today's topic will focus on how to support your pregnant patients in deciding whether the COVID-19 vaccine is right for them. I know some people are still joining, and a lot of our participants are going to be watching the recording. We have a lot to cover, so I'm just going to continue on. My name is Dr. Nazanin Homayfar, and I'm an OBGYN practicing in San Francisco, and will be moderating today's conversation. I'm also the medical director at June Motherhood, a digital health company that partners with prenatal healthcare providers all over the country to offer the next generation of support for pregnant people and families. Our platform combines expert coaching, education, and a small group support system to empower expecting parents throughout the pregnancy and postpartum journey. I'm so excited to dive into our discussion today. The COVID-19 vaccine will soon be available, if not already, to all of your pregnant patients. But many patients still have questions about what the vaccine may mean for them and their families. Our discussion today will center around 4 key parts. We'll start with a brief update on what we know about the COVID-19 vaccine from Dr. Elizabeth Morgan. When I say brief, it's rather detailed, but we'll try and get through it quickly. We'll then introduce one of the most popular decision aids created for pregnant people regarding the COVID-19 vaccine, designed by Dr. Katie Barker and her colleagues, including Dr. Morgan. Next, we'll turn to experts on decision aids, Dr. Mary Ann Durand and Renata, to provide guidance on how to incorporate these decision aids on a daily basis. And finally, we'll leave about 10 minutes for Q&A at the end. I'd like to get started with Dr. Elizabeth Morgan. She's a maternal fetal medicine specialist at Bay State Health with a background which is so unique and so timely in emerging infectious diseases and pandemic preparedness. She is part of the COVID-19 working group at her hospital and has testified on COVID vaccination in pregnancy on a state level. Dr. Morgan, welcome. There's been a lot of confusion and misinformation surrounding the COVID-19 vaccine for pregnant people. Can you give us a quick overview on why and what we know today? And I'll actually have you also if you can prompt Tina on your end as to when you want the slides changed to.
Absolutely, and thank you so much for having me. So first, there's been a lot of confusion and a lot of misinformation surrounding the COVID-19 vaccine in pregnancy. And I'm going to get on my Zoom soapbox now, which is that unfortunately, many of the reasons for it is that pregnant people were not included in the original vaccine trials. So in fact, many of my colleagues from around the country have used this as a particular example of how admitting pregnant people in vaccine trials, especially during a worldwide pandemic, and they've really used it as a rallying cry to push forward the inclusion of pregnant participants in further clinical research. So exclusion of pregnant people in clinical research has been an issue for some time, and I think this pandemic has really brought the problem out of the light of day. So getting off my soapbox, we do actually have a lot more information on the COVID vaccine in pregnancy now, which is actually incredible when you think about it because of the sheer speed at which the vaccine was developed. I love these 2 images from Nature that came out because they really show the timeline for vaccine development over the past 2 centuries. So if you can look at typhoid fever, year in which the pathogen was linked to the disease was 1880, but when we actually had a vaccine license, that was in 1980. And COVID really has just been a little blip on that scale, having been developed in under a year. So the next timeline that I have, if you could change the slide, shows that on January, it's kind of packed, but if you can see on January 10th, and now remember, this is 3 weeks before the SARS-CoV-2 outbreak was even declared a pandemic by the WHO, they already had the first draft of the genome made publicly available. By March 16th, which is a mere 2 months later, they actually had the first phase 1 clinical trial started by NIH and Moderna. So we received our efficacy data based on tens of thousands of participants for both Moderna and Pfizer mRNA vaccines in November 2020, just 8 months later. And they received emergency use authorization, we remember, in the very near past between December and January 2021. Unlike some other countries, when the mRNA vaccine was released, the FDA and CDC here recommended the vaccine not be withheld from pregnant and lactating people. They did this despite their exclusion from clinical trials because of the vaccine's high efficacy, over 90% for the mRNA vaccines, and a low theoretical risk of harm that I can talk a little bit about later. But emerging data on long-term risks of COVID-19 in pregnant patients were that pregnant women could be severely affected. So I remember as a maternal fetal medicine physician holding my breath around this time because it's not the case in some other countries. And it really would have been a significant loss of autonomy, I think, for our patients. Since that time, the CDC has been collecting information on vaccination and pregnancy through their vaccine safety pregnancy database. So you guys might know this is the vSafe pregnancy registry. And if you can go to the next slide, this is from the CDC.
Dr. Morgan,
yep.
Can I interrupt you for 1 second there? Because you said the CDC and FDA did approve it. Who else helped them make that decision? What other professional organizations?
So there was a lot of conversation between from the Society for Maternal Fetal Medicine and ACOG to help kind of work with that policy so that when initially the information came out and when we got the emergency use authorization, we quickly followed, I would say almost preceded it to make sure that it was not excluded from pregnant women.
Thank you. You were talking to us about the CDC and VCare. I apologize, vSafe.
That's fine. So, I just wanted to pull up this slide so you could kind of see broadly how the database works. And then the slide after, which is the next one, actually shows a little bit about the contact timing. So when vSafe participants are actually contacted once per trimester after delivery, and then when the neonate is 3 months. And this is a little bit of information as of February 19th, just in terms of how many participants they had to date. So the next slide is the really important one because that was presented recently by ASIP. So that's the Advisory Committee on Immunization Practices. And that shows so far they haven't found concerning signals. And this is again on the mRNA vaccines. But there hasn't been shown to be any significant increase in congenital anomalies or birth defects, neonatal death, growth restriction, small for gestational age, or preterm birth rates. And I think it's really important to remember, especially as we start to discuss aiding our patients in making decisions that are best for them, all of these risks of vaccination are not in a vacuum. So this is compared with baseline risk, but we should also be comparing it with risks of contracting COVID-19, such as prevalence risk in community and patient occupation, and risks of COVID-19 to the particular patient. So we know that some of our patients that are older, obese, diabetic, or have another health condition are even more susceptible to this virus and are more at risk. And I want to emphasize that we do know, even a year into this, pregnant people are at higher risk of severe disease just at baseline. So we know that they have higher rates of hospitalization, ICU stays, and even intubation than their non-pregnant peers.
I mean, this is incredible. Like when you think about this timeline and the fact that we have data on 1,900 patients so far, I think what's confusing to patients is like how to process this data. How are we making it visually available to them? Because as you are well aware, and probably everyone who's joining, there's so much misleading information on the internet. So I think one thing that I wanted to talk about is that a piece you co-wrote that was published in August called "Why Good Enough is Not Good Enough. Scientific data, not supply chain deficiencies, should be driving Centers for Disease Control and Prevention recommendations." And this piece focused, I think, early on recommendations the CDC was making regarding adequate personal protective equipment during the second stage of labor, or when people are starting to push. And you wrote in one line, quote, "As healthcare professionals, we understand that the absence of data does not equate to negative data." Would you say that this sentiment also applies in the case of the COVID-19 vaccine?
Yeah, I mean, absolutely. And I have to say that whenever I talk to my patients, I always have in the back of my mind that this is the data we have now and these things can always be changing. I think as scientists, we need to remember, right, that we may never have all the data and things certainly evolve. And it's precisely why we have discussions on this with our patients. Everybody's interpretation of the data is going to be unique to their situation, and everybody's risk tolerance is certainly going to be different. And I think what's really important to remember too, especially in that article that I wrote, is that sometimes there's more data out there than we suspect. So not knowing about data is not also always a lack of data. It's why I try and keep up to date with any new information. It comes out very frequently, and I can put up some links of some places that I go to. But also it's really important because at the beginning of this pandemic, I know I spent a good deal of time, and I'm sure many epidemiologists did, of going back and looking at lessons we learned from past pandemics and even from SARS-CoV-1. And that helped us a lot, I think, create some of our future policy in times of uncertainty when we didn't really know how this disease was going to react. And then the other thing that I think is really important to remember is we really have to be aware of our own biases and make sure that we're incorporating new information as it becomes available and that we're continuing to grow and adapt. I know we talked a little bit about some of our professional societies like SMFM and ACOG, but I really think they've done a terrific job in just the face of all these uncertainties, continuing to develop and recreate and rewrite guidelines based on our evolving information.
Absolutely. I think very early on, they tuned into creating information for providers first. And then I think, and all of them now have resources for patients. It's about, in this day and age where there's so many sources of information, figuring out how to direct our patients to the right sources of as close to the truth as we can get. Right. And so on that note, I did want to talk, we have people joining here who will likely be familiar with the vaccines, but I want us to go into a little bit more detail. We've heard most about Moderna and the Pfizer vaccines, and as of February 27th, the Johnson & Johnson vaccine also got emergency use authorization for its single-dose vaccine. Can you give us a quick rundown? I know, like a quick rundown of how each vaccine works and its efficacy.
Okay, and I will try and make it quick, just not by speaking very quickly.
Thank you.
And then another thing that I do tell my patients, since we're talking about information and where they can go, is one of the things that sometimes when I don't have all the information or I want to make sure that they're on the internet and looking at the right places, I usually tell them, feel free to Google it, but try and stick to .edu and .gov. So in terms of the vaccinations, I think the most recent one to come out, which people may not be as familiar with, is the Johnson & Johnson vaccine. It's also known as the Janssen Biotech. It's the one-dose vaccine. And that one, unlike the mRNA vaccines, uses an adenovirus vector. So it carries the gene for the coronavirus spike protein, and that spike protein is how it enters the host cell. And that's what most of the vaccines are targeted towards. Luckily, with the Johnson & Johnson vaccine, we do have a better understanding in pregnancy because we've had similar vaccines that have been trialed in pregnant people. So vaccines for Ebola, HIV, and RSV, while not widely in use, have been tested in pregnant women and have not shown adverse pregnancy outcomes. So at least a little more information on these ones. Currently, it's authorized for ages 18 and up. And again, it's a one-dose vaccine. So I think people focus on the efficacy. It's 72% efficacy for moderate disease. What I think sometimes the media doesn't focus on, which is equally important for our patients, is that it's 85% efficacy for severe disease. And importantly, 100% against COVID-related hospitalization and death protection. For our patients, that number really makes a difference too. Like mRNA vaccines, and I'll kind of go into those briefly, we believe the risk to the fetus is low because while in this one, the viral DNA enters the host nucleus for transcription, it's not integrated into host DNA. So it's slightly different than the mRNA vaccines, and that's the Pfizer, BioNTech, and Moderna. Those ones utilize small bits of genetic information. So the mRNA stands for messenger RNAs. They're within a lipid capsule, and it gives our cells the instructions for how to create a protein unique to that virus. So the same spike protein, and then our bodies build those T lymphocytes and B lymphocytes in response to it. And this is obviously what later helps us and protects us. Because mRNA degrades really quickly after it's injected, we think that the vaccines in pregnancy are probably theoretically thought to be very low for these mRNA vaccines, even though they haven't been widely tested. Mm-hmm. Additionally, I think one thing that I like to talk to my patients about is that they don't contain preservatives like other types of vaccines. It really is just that mRNA and the lipid capsule. There's 4 different lipids that you can look up, and that's why they require those extremely cold storage temperatures, but they rapidly degrade, they don't have preservatives, they do not enter the nucleus of the cell at all. So we don't think they can integrate or interact with DNA. And though they're the first mRNA vaccines in use, and this I want to come full circle to this idea that there is often some data out there, even when things are new, The delivery system has been studied for over a decade, actually, prior to current distribution.
And I think there are a few things that I just want to emphasize as key points when talking to patients is that these vaccines do not integrate into your body's genetic makeup. So from what I'm hearing from you and from what we understand, what in either case, the makeup of the vaccine either degrades or is not incorporated into how do I word it? Like into further data replication. So there's no long-term effect on you or the potential, at least theoretically, of integrating into the fetus's genetic makeup as well. In terms of, I was going to keep questions to the end, but you had touched upon this and I want to make sure our participants hear this. Can we go back to the VSafe pregnancy registry of outcomes? Like, what's the latest information we have regarding fetal effects long-term? Is there anything you could potentially conclude from the data we have so far?
So I think so far, I mean, it's just kind of what we had talked about a little bit, but I know fertility has come up. They don't see any increased risk in miscarriage right now. They're continuing to collect data. There still haven't been any signals showing any increased risk in growth restriction or stillbirth. But there is some really good new information talking about some of the efficacy of the vaccine in the neonate.
Can you tell us a little bit about that new data on vaccine safety in pregnant or breastfeeding people and potentially for the neonate?
So one of the things I think I initially talked to patients about, but we were still kind of waiting to see is, like with other vaccines, there is that possibility that antibodies could cross the placenta and actually help and be protective for babies. And we were wondering that about breast milk too. So actually the first peer-reviewed report was actually from a colleague of mine in Minnesota, which was very exciting for me. And that was Dr. Gill. And she published in a Green Journal on March 8th, so about 3 weeks ago, demonstrating that COVID-19 antibodies were found in the umbilical cord of a vaccinated mother's neonate. Since that time, again, only 3 weeks ago, we've had multiple studies showing IgA and IgG antibodies crossing into breast milk. There was a study in Israel among 20 women who had been vaccinated showing antibodies. And then most recently, I think one that's gotten a lot of attention in the press is that Boston did a study and they looked at 115 pregnant and breastfeeding patients. Not only did they show transplacental antibody passage and antibody passage in breast milk, but interestingly, and I think this is really important for patients, they found that antibody levels in the babies of women who were vaccinated were actually much higher than those who had COVID itself. And they were looking at a specific time period as well.
So what is the potential significance of that? Because why would that be important for us to know?
Well, I think it's really important for a couple of reasons. First of all, the first thing I think we think about as mothers is how can we protect our children, right? Most of these vaccines you have to be either 16 or 18. Trials are still ongoing in children. We never know about, especially in early neonates until we do those trials, whether or not they can be vaccinated directly. But we do have information like we have with the Tdap that, vaccinating the mother can help protect the baby. And I think this is just one other point in that direction that for breastfeeding moms, for moms who are pregnant, that this could be protecting them. There's still some things I think we need to find out. When in pregnancy, for instance, would be the best time to vaccinate. I don't think we know that for sure, but I definitely think it's one step on that evolution of information that we have.
Amazing. Thank you so much, Dr. Morgan, for setting up the foundation of our talk. Now that we've heard about the safety profile and research behind the vaccines, I'd like to move on to Dr. Katie Barker, a general OBGYN at Bay State Health with a specialty in informatics. And Dr. Morgan, if any questions come up, we will address them to you at the end. Dr. Barker, I'd love to talk about the tools providers on this webinar can use in discussing the COVID-19 vaccine with their patients. I remember early on having a co-resident of mine on a WhatsApp group share your decision aid, the one that you helped create with many others, and I forwarded it to my department, and pretty soon I was seeing it in various Facebook groups for professionals and having other people send it to me. How did this decision aid come about?
Yeah, thanks so much for having me. I'm really excited to get to talk to some other providers about this tool that that has taken off, as you said. So about a week before base date, where both Dr. Morgan and I practice, was supposed to receive its first shipment of vaccination for healthcare workers, the chief physician executive of our large provider group got together about 10 of us on a WebEx call to recruit us to be what he dubbed vaccine influencers. Essentially, he wanted to share with us some information that he had and some hopes that we would come up with our own ways to help support and increase the acceptance of the vaccine among healthcare workers. And during this WebEx call, one of the ER doctors who was on it, Dr. Lauren Westifer, was privately messaging me, hey, a bunch of the residents in the ED are pregnant. What are you obstetricians telling your pregnant residents or nurses about the vaccine? And so we were talking a little bit back and forth about how we're going to share the information that we have. And then sort of parallel to that, a patient of mine who happens to be an infectious disease specialist, a physician, she was also talking to me about the vaccine, and she had her mind made up before I had a chance to talk to her about it, essentially. And so we sort of pitched the idea to the chief physician executive of sharing the story of our conversation about deciding how to, or whether or not to get the vaccine while pregnant. So it was sort of this confluence of the three of us talking about how do we make these decisions and how do we share this information that sort of planted the seed of this shared decision-making tool. And then Dr. Westifer went back to the ED and was talking with one of our local experts on shared decision-making, Dr. Schoenfeld. And so the two of them and our maternal fetal medicine department got together and put together the first draft of this shared decision-making tool. And at the same time, a local newspaper asked to do a story on myself as the provider and my patient, the infectious disease specialist, Dr. Westlake. And they did a profile about our discussion and our shared decision-making about the COVID vaccine and pregnancy. And from there, it sort of took off. And our marketing team said, let's try and spread this story. We think this is useful and helpful. And as a working group, this shared decision-making COVID vaccination working group, we decided to just share this however we could, because we got such positive response from our colleagues within the hospital. So we started sharing it on social media. We started sending it to listservs that we were a part of, national, international. And like you said, before we knew it, it had quote unquote gone viral, which my kids think is very cool, because I certainly have never been viral for anything before, thankfully, I think. But so that's sort of how it got created. And since then, this small working group, just every time there's a new piece of information, we update it and share it and edit it and release the new version.
I mean, I think it's just so innovative and so needed, because I think we've all, as providers, been so burdened with, and not in a bad sense, but with new information. How do we process it? How do we then address the questions of our patients? We said something one week, but we're changing our mind the next week. And so I think having this tool as a way to lay it out to patients so simply has been, when I came across it, I was like, this is perfect, because our lives are busy, and to take the time to create something like this and have a team that's really focused on it is so incredible. So I want to thank you, because you've made my job easier in being able to talk to patients in a way that's meaningful, in a way that makes me feel like we can at least listen to their concerns and lay the information simply to them. And when I reached out to you on Facebook and I got a response, I was like so excited. I had a fangirl moment. I was like, the creator's going to come talk to us, one of the co-creators. So tell us, I would love to hear, because you helped create it and you use it on a daily basis. Can you walk us through the decision aid and how it should be used?
Yeah, sure. I mean, I also use it on a daily basis. So, it was absolutely a team effort. Dr. Schoen and Schoenfeld, we have lots of very similar names in this working group. And Dr. Morgan were really sort of the heavy lifters at the beginning of the content. And the rest of us contributed to sort of layout and design and usability. So I practice general obstetrics. I see a lot of OB patients in my office. And every day I have a conversation about this, and I have a little file on the wall in each of my exam rooms that has it. and also a QRC code if people want to take a, get it electronically. But I basically say to my patients, hey, have you thought about the COVID vaccine during your pregnancy? And I see what they say. And many of them start off with the same thing, which is, yes. There's this huge hesitancy because I think when women are pregnant, they want an answer of, is this safe or not safe? And we can't give them that black and white answer in this regard. So we can only help them assess their own risk and assess the risk of COVID and the potential risk of the vaccination. So I say to them, well, this is a tool we created here at Bay State, and I want to give it to you, and I want to walk through it with you a little bit, because I hope this helps you make the decision. And I quickly review that, while neither of the first two vaccines were tested in pregnant women, we thankfully do have data that Dr. Morgan went through now about some women in pregnancy. And so that's really helpful and that's really positive. But what we also need to make sure we do is, and if you want to go to the next slide, because this is where I really spend the majority of my time, is this block 2, thinking about your own personal risk. So I spent a lot of time talking to them about how we don't know what the vaccine, how well it works or doesn't work in pregnant women, but we know a lot about COVID. And we know a lot about the dangers of COVID. And so I asked them to sort of reframe their thinking around the known risk of COVID versus the unknown risk of the vaccine. And I don't even say theoretic risk, because I don't think we believe scientifically that there is a theoretic risk. I think we just don't know what it is. And so I encourage them to sort of work through this checklist, and I encourage them to talk with their friends and family. And like Dr. Morgan, I also encourage them to go to reputable places like .org and .edu and .gov websites when they're looking at it. And I ask them to ask me more questions at their next visit. And so I always leave the door open for them to have a continued conversation, because I think they need to know that I'm going to partner with them no matter what, whether they decide to get the vaccine while pregnant or wait. They need to know that I'm going to support them no matter what they decide. I just want them to make an informed decision.
That's Dr. Durand and Renata will be speaking to that a little bit in a bit. Did you test this on an audience before publishing widely?
Yes, poor pregnant doctors in the hospital and nurses. We showed it to lots of them, and they said, do they think it's helpful? And I'm in the faculty practice, and so I actually care for a lot of nurses and doctors who are pregnant, and they were so excited to have this. They're like, oh my gosh, this is so helpful. And so we did sort of beta test it, if you will, in fact, it was really designed for internal use at the beginning. So we tested it with those folks, and then it went off from there. We also have a survey at the end of it. In the initial, it was a bigger piece in the sort of first iteration of it, for people to give feedback on the tool, and we incorporated that feedback into subsequent iterations of it.
Amazing. And we did send out the link to the decision aid to our attendees. And as you'll see, we'll talk about this, but it's available in multiple languages. How you talked to us a little bit about how you use the decision aid on a daily basis in clinic, but how has it been used at Bay State Health? Are you pushing it out to people? Are you just keeping it in the clinic setting? Like, how's it being used?
Yeah, great question. So it is on both the internal website, so our internet page for employees. It's also on our external facing, our public facing website in the giant banner bar of COVID-19. And so there's a link to it in both places to get at both our patient audience as well as our employee audience. We've also uploaded it to our patient portal, so patients can, on our patient portal, search for information about a variety of conditions. And when you search COVID-19, this comes up. We also utilize a tool. It's not widely rolled out yet. We're still in the pilot phase, but of a remote prenatal care program. And so we pushed it through that as well. We also have it laminated in bathrooms. We have it in waiting rooms, even though patients don't spend much time in those anymore, thankfully. And so we have it visibly posted in prenatal care areas, as well as electronically posted, and then through our remote prenatal care app as well.
Do you, and I don't know if you've had a chance to look at this, but have you seen where the uptake has been greatest in these different areas? Do you know when you get the most questions about it?
Great question. Definitely the conversation with the provider is where you get the most impact. So having that conversation, having this be a tool that helps facilitate the conversation about vaccination, that's where we're getting the most sort of um, impact with it. We certainly, I don't think anticipated that social media would be such a big piece of this, but that certainly has become a huge piece of it. It's funny that I've had it shared with me from people who don't know that I was part of the group that was creating it, which is always really fun. Somebody says, "Oh my gosh, check this thing out. It's so cool." I'm like, "Yeah, thanks. I think it's cool too." And we've also seen it used lots of, very reputable national and regional health institutions have adopted it to their needs. So we know that it's being used by areas of Kaiser, and we know that it's being used by Boston Medical Center, and it's being used even I think we most recently heard that the Irish counterpart of ACOG has adopted it and is using it as their national and standard platform. So it's been really fun to see where in the world it's found its way. And our goal in creating it was to have open and free access to it. So anyone has access to an editable version of it to make it what they need and what they want it to be for their own institution and their own population.
That's incredible. Yeah, that was one of the questions, if people could freely use the decision tool. And I think you answered it. So it's now available on the Foamcast website that we gave, but any other information for people who might want to share it?
Yeah, what is most important to us is that every pregnant woman is given a space to have a conversation about this. No one pregnancy and no one person is going to have the same risks and the same potential benefits from the vaccine. And so we just want people to be able to have the conversation. And if it's this piece of paper or this website that starts that conversation, we're thrilled. And so we don't mind, we don't really care how it gets to people. We want it out there so people can share it on social media. They can put their own branding on it. That's not what's important to us. What's important to us is that the conversation is happening.
Amazing, thank you. And did any unanticipated questions arise from the decision aid? And how about when you provided it in another language?
Yeah, it was really neat. When we first started sharing it, we had people volunteering to translate it because they knew that it was, going to be so helpful, especially in groups where we see increased vaccine hesitancy. And sadly, we do see that through certain socioeconomic groups as well as certain ethnic groups. And so it was really neat to have people volunteering. Our in-house translation service did the heavy lift of translating it into 10 different languages. I think questions that we struggle the most with are questions about fertility, because this is a guide for pregnancy. And so it's not necessarily a conversation that you're having with somebody who's thinking about becoming pregnant. So we've toyed back and forth about, do we put it in this, do we create a different one? So that's one area I think that that we get questions about a lot. And we, as Dr. Morgan said, we just, absolutely say we don't have any data to support that has a negative impact on pregnancy, for sure.
Mm-hmm. And I'll direct also, if any of the panelists have any questions about that, the American Society for Reproductive Medicine has also put out statements about specifically fertility, which is their area of expertise. In case anyone wants, we can share that later. Do you foresee making any updates to the decision aid with, for example, the new J&J vaccine? I think you have already made that update, but anything in the works?
Thankfully, we're a pretty nimble team. Changes happen rapidly, and the team is sort of well equipped to do that. So J&J is already included in this most recent version. The big piece of data that absolutely is going to be included in the next piece is the data that Dr. Morgan already alluded to about the 2 studies that are coming out showing the antibodies in the newborns who were born to vaccinated moms. So that certainly is going to be another big addition to it. And yeah, I think we'll keep editing it and adding to it as we get more data. We want this to be accurate. As you said, we want this to be easy for providers. We don't want them to have to, fill in too many holes. And so we're going to keep updating it as data comes out and as long as people find it useful.
Amazing. Thank you so much, Dr. Barker. To our audience, we've provided you with the information and tools for discussing the decision aid. You've heard from the co-creators about how they utilize the decision aid in their everyday practice. I want us to move on and hear from experts in healthcare communication to see how we can make sure we're using our tools effectively. Dr. Durand, you are a health psychologist with a doctoral degree in medicine and primary research interest in healthcare communication, disparities, and shared decision-making. You are also a lead investigator and co-creator of the Option Grid and Picture Option Grid as decision aids created for a variety of topics, including prenatal topics on genetic screening and more recently COVID-19 vaccination. I encourage our panelists to search for those, as I found especially the ones on genetic screening to be incredibly helpful. Renata, you're a PhD candidate who works closely with Dr. Durand and are currently 24 weeks pregnant. Congratulations. Many of us are very familiar with patient decision aids and may have used them previously. Can you tell us very briefly about the research behind decision aids?
Yes, we'd be delighted to tell you more. So patient decision aids have been developed since the 1990s, and these are interventions or tools to help compare reasonable evidence-based information, as Dr. Barker showed you, and they provide risk information in a way that patients can understand. There is strong evidence from about 100 randomized controlled trials that patient decision aids increase patients' knowledge, they improve patients' understanding of risk, and they lead to more preference congruent options. So we mean by that the choice that the patients or the people make will be more aligned with their stated preference and the information that they have received. There is slightly weaker evidence suggesting that patient decision aids can also reduce costs, so not for the patients, but for the healthcare system. They can also improve adherence to treatments and improve communication.
I think it makes total sense. And I think the challenge is how to create a decision aid to then achieve those goals. We know general tips on using simple language and sentences to communicate with patients, though I must admit, as a medical professional, it can be easy to forget at times. We just throw jargon in there without even realizing it. Do you have any recommendations on how to introduce decision aids into the conversation?
Yeah, so we recommend a simple model that you can see here on the slide. And it's 3 steps, and it's called the 3-talk model. It's developed by our colleague, Professor Glenelwyn at Dartmouth. And we've also are going to share a link in the chat so you guys can link to the article that talks about the publishing and development of this model. And the first way you introduce the decision aid is team talk. And that's, you can see that here in purple, to indicate to the patient that you, as the healthcare professional, are going to work together with the patient and as a team. And it's important to make patients aware of choices that need to be made and provide support and guidance. And so to achieve team talk, you can use sentences like, let's work together as a team to make a decision that suits you best. And the second step is option talk. So you can see that here in pink. And this is when you introduce the patient decision aid in the conversation. So it's about comparing options in a neutral and balanced manner and communicating risks in a way that all patients can understand regardless of their health literacy. And to achieve option talk, we recommend sentences like, I would like to show you something that can help us compare options. It's called a patient decision aid. And you can use the teach back method at the end of option talk to make sure that the patients are understanding what you're going through. And finally, the last step is decision talk, which you can see here in green. And that is focusing on patients' preferences and how you move eventually to finding a decision. And sentences like, tell me what matters to you for this decision can be used to achieve decision talk.
Can you tell us, I'm sure everyone's familiar, but I just want to make sure, what is teach back?
Yeah, so teach back method is when you ask the patients to repeat back to you what you have just spoken about. So can you tell me in your own words what we've just talked about, or something to help the patient sort of say out loud what you've just said so that they can sort of internalize what you've been talking about.
That's great. And I find when there are certain ways that I love how someone has phrased something, I will write it out for myself and put it somewhere, especially with EMR, we have little sticky notes, and I'll actually put that sentence in so I can get used to saying it over and over again. So what I heard from you is with team talk, we say, let's work together as a team to make a decision that suits you best. Something so simple, but I think so impactful for a patient. And then the other sentence, so that if any of our attendees want to take note, I'd like to show you something that will help us compare options. It's called a patient decision aid. And then finally, with decision talk, tell me what matters to you for this decision. So 3 sentences that can really help guide this somewhat complicated discussion, and maybe not so complicated once we actually get a sense of what is important to the patient. Now that we have that, what's the word I'm looking for? Sometimes if I haven't had enough coffee, I forget. Well, now that we have that framework, can you tell us if there's any data to suggest whether there are whether decision aids are most helpful when we push them to patients or via EMR or mail, or when we go through a decision aid with a patient directly, as Dr. Barker is doing?
That's a great question. And I think it really depends on the patient or on the person or people you're seeing, on the workflow and on the health professional. So we know from studies that some patient will find it helpful to receive a link to the decision aid emailed to them from the EMR or on the patient portal. Other people will prefer to get a paper copy during the consultation, before the consultation, that they can take home and share with other people. It also depends on their health and computer literacy levels. And in some workflows, it will be easier to send decision aids ahead of time and for clinicians to use them during the consultation. Doing both can work really well, and it sounds like that's exactly what Dr. Barker has been doing. And integrating the decision aids in the EMR can also be a very good option to sustain the use of decision aids and to really fully, routinely integrate them in your workflows. And we're learning that from implementation studies we're conducting at the moment. But we know that a full integration into the EMR in your hospital can take time and it can take money as well. But from what we're learning, it's worthwhile for sustained long-term use.
So important to know. I know at our institution, trying to implement changes through EMR can take months at a time, but it sounds like it's well worth the effort if it's a discussion. I can imagine around vaccination or even genetic screening that's going to happen over and over again. You've also done research on how decision aids and plain language communication can be particularly helpful for underserved communities. Can you talk a bit about your research here and any tactical examples of how to implement this in someone's practice?
Yeah, absolutely. So the International Patient Decision Aid Standards, which is sort of the oversight body for patient decision aids around the world, they recommend that decision aids are written at a 6th grade reading level and using plain language principles that we've talked about. In practice, this actually really isn't done. We were both a part of a systematic review that was done recently, and it found that every single decision aid we reviewed did not meet this threshold of a 6th grade reading level. Overall, the general recommendations, and we've called out some of these already, but again, plain language principles that include sentences that are shorter than 15 words, always using the active voice, using bulleted lists for written content as much as possible, and selecting essential gist information only so that the patient can get the meat of what they're trying to review in the moment. And then also a really great approach is using readability software, something like readable.com, where you can run the text of your decision aid through a software that will tell you what the reading level is and ensure that it's readable at a 6th grade level. It's also what we've seen in the research and what we do in our practice is including patients of all health literacy levels, particularly those of lower health literacy levels, lower socioeconomic status, in the development and the testing of decision aids to ensure that the readability adequate across the spectrum, no matter what the patient is in terms of their health literacy. And then the other thing that is clear from the literature, and we've done a systematic review on recently, was that pictures can really help, and particularly for patients of lower health literacy. So the review that we published recently included 54 randomized trials, and we found that when pictures were included, they improved understanding and information recall.
I have never heard of readable.com, and it sounds like a fantastic resource. Do you know if they provide, is it only for English, or can you use other languages in Readable?
I'm not sure. Marianne, do you know the answer to that?
I think it's mostly English. I know that for French, I have to use a different software, but I'm not sure about Spanish, actually. I will double check.
Maybe it's, if we find something, we'll share it with our audience, but it's great to know, because I think not everyone has access to the resources. Like, I know at one of the hospitals that I work at, there is a team that will go through information and help you make the language much simpler and at the 6th grade level, but not everyone will have access to that. So readable.com is a resource that people can use. Can you take us through, as the experts in healthcare communication, can you take us through a role play of what a conversation with a patient may look like using some of the frameworks we've discussed today?
Yes, absolutely. So I'll be the clinician. I'm not a clinician, so bear with me if I say something silly. That's normal, doesn't matter. And Renata will be our patient, our pregnant woman. She is anyway. Good morning, Renata. It's really nice to see you today. I think you're here to talk about the COVID-19 vaccine.
Yeah, good morning. Yeah, that's right. I received the decision aid that you guys mailed me, and I was able to read it with my husband before I came here today.
Okay, well, that's excellent. So before we start talking about it, I'd like you to know that I'm so glad that you came to see me today to talk about this. And if that works for you, I'd like us to work together using the decision aid that you've looked at to try and make the right choice for you.
Great. Yeah, that sounds great. Thank you.
So there's no right or wrong choice here. That's why we're using the decision aid to compare the option about having the vaccine now or later, and choose the right one for you and also for your family. So just time out. I've just done team talk, and I'm now going to start option talk. So since you've looked at the decision aid, do you have any questions for me?
Yeah, so I'm 24 weeks pregnant right now. And I guess my first question would be, I'd really like to know if it's better for me to wait until the 3rd trimester or to have it as soon as possible, because I'm in my 2nd trimester right now.
Well, that's a great question. And based on what we know so far, there's no one trimester that's best. It looks like a vaccination in the 2nd half of pregnancy. So roughly from now on for you might be more beneficial. So time out. I've done the option talk. I didn't go through all of the options because she had already received a decision aid. And I'm now trying to see through her question how a preference might be forming, and thus navigating between option talk and decision talk. Back to you, Renata.
Okay. Yeah, I hadn't realized that. Okay, that makes sense.
Do you have more questions?
Yeah, so my next question would be around whether or not, I've seen all the recent articles about the Johnson & Johnson vaccine, and I'm wondering if I should try to get one vaccine over the other, if there's any evidence around that.
Oh, that's another very good question. Well, at the moment, we're not able to recommend getting one vaccine over another. At this point in our hospital, we'll probably only be able to offer you one of the mRNA vaccines. And we cannot be sure if it will be the Pfizer or the Moderna vaccine.
Okay. All right. That makes sense. Thanks. So yeah, one more question. So, my risk is quite low right now. I'm thinking about, I'm home with my son and my husband, and we're all pretty low risk, but I'm thinking about when I go to the hospital to give birth, I'm going to be there for a while. I won't be masked. Should I get the vaccine in order to be protected when I give birth, even if my risk is really low right now?
Well, I'm really glad you're asking this, because this is something really reasonable to consider as you're making the decision. And yes, for the vaccine to work as well as possible, you need to have received your second dose, and that's something to consider. And you need to have done that at least 2 weeks before you give birth. So you would also have to keep that in mind. So now that you have a bit more information, you've looked at the decision aid, and I hope that we've answered some of your questions together. Do you have an idea of what you might want to do next?
I'd love to go back and talk to my husband, bring back these questions that you've answered for me, and I'll get back to you guys if that's okay.
Yeah, that sounds great. And really don't hesitate to reach out to me or some of my colleagues if you have more questions that come up.
Thanks.
Okay, and that's the role play. So we tried to show you how to navigate between these team talk, option talk, and decision talk, knowing that it's not linear. There can be movement, and a decision aid can help you with team talk, and then from team talk getting to the preferences with decision talk.
Thank you so much to you both for doing that. I think it seemed so effortless. And one of the questions I had is like, what do you do when the patient asks your recommendation and what you would do in their case? Because that's what I'm usually, I think I fully appreciate leaving it kind of in the lap of the patient to help weigh these risks. But then ultimately I'm getting a question, what would you do?
Yeah, that's a question we often have when we train health professionals. So being asked that question doesn't mean that you can't promote shared decision making, and you can still get from the patient their preferences, either now that they've asked you that question or having heard it before, to say, well, based on what I've heard that you've told me, this seems like it might be the right option for you, and it might not necessarily be the right option for me, but I've heard your priorities, your values, the things that matters to you. And from all that, I think that might be a good option. And then you can see if the patient feels that way, or if you perhaps have misunderstood, or they haven't fully declared what their preferences or priorities might be.
So we are able to answer the question, but use what we've heard from the patient, which I think I do this a lot with contraception counseling, when I'm talking about what someone might want, and they ask me, what would I do? And I say, the most effective form of contraception is what works for you, and what works for you may not work for me. So in the same sense, we could provide that. We can say that in the case of the vaccination too. Listen to what the patient is prioritizing and help them. It's still okay to give a recommendation based on what they're telling us their priorities are, and we could say, this is what sounds like might work best for you. Dr. Barker, Dr. Morgan, anything to add to that? If not, I have more questions about vaccine hesitancy, which is very real in our country. How do you recommend we approach vaccine hesitancy with these decision aids?
So we recommend that you first hear what the concerns might be. So same as what we did in, option talk and decision talk, trying to listen to Renata's questions. She didn't have many concerns, but if she did, I would have received them fully and try to provide some information, send her back to the information that's not there, and use the information that's evidence-based to kind of bounce back her concerns and try and see if we can find answers. That's how we recommend it's typically done. So really, instead of pushing back and saying, well, no, that's not a valid concern, really trying to welcome the concern and use the best evidence available to answer. And if there's no data to really answer it, then saying, as we did in the role play, we're not exactly sure, but this is what we know and what we think might be the case right now.
Thank you. And Dr. Barker, have you had any experience in sharing the decision aid with people who expressed, I know you said people expressed a little bit of hesitancy, being like, yeah, I have heard of it, but have you come across anyone who has had major reservations, and what have you found to be useful in navigating those?
Yeah, I think it's funny. I had this reflection the other day. where like, I think any prenatal care provider in the audience can appreciate the experience of talking to a pregnant woman about getting the flu shot, right? There is an abundance of data. We know that influenza vaccination in pregnancy is very safe, that women like, and so I think sometimes I go into that conversation, or I would say used to go into that conversation with patients sort of like, ugh, here we go again. I'm gonna have to try and convince this patient that they should get the flu shot because I know with all the science that she should. And I have been really pleasantly surprised by some women who I've taken care of through multiple pregnancies who've never gotten a flu shot before in pregnancy. I'm now having success and helping them get a COVID vaccination, which is like, you know, if they're afraid of what might happen, you know, statistically, they should be more afraid of COVID vaccine than flu vaccine because we have so much data about the flu shot. And so I'm definitely recognizing just how much power this shared decision making has in helping a patient come to their own conclusion with a partner and their prenatal care provider. And the term and concept of shared decision making is certainly something that I've always tried to practice in all ways that I practice. But I found it's incredibly helpful to have this tangible tool to help guide us both through it. Because I think at the end of the day, women or pregnant patients want to feel heard, and they want to feel like they have a trusting relationship. And if you tell them, I don't know, that helps, right? So if you say, I don't know the truth, but here's what I do know, and here's how that's helping me. So certainly I have found that this tool has really been more successful than I imagined in those patients who are in general more vaccine hesitant.
Mm-hmm. And I think it's a very powerful thing as providers to be able to say, I don't know. It's something we've always known about our field. It's not, you know, this is what practicing medicine is. And I think garnering the trust of the patients that we will help them make the decision that best suits them, but acknowledging and being humble about the fact that we don't know. So I think that's a very important pearl to leave our audience with. I know there was a question from the audience, and I wanted to make sure I'm aware of the time, if we can just have a few more minutes. One of our participants asked, are there any studies suggesting when is the best time or trimester during pregnancy to receive the vaccine? Dr. Durand alluded to this in the role play. I know Dr. Morgan, you briefly mentioned it, but do you have any data that can help guide someone as to when the best time might be for them?
I think in terms of the trimester, you know, we don't have specific data really yet. We're still, I think, looking into for two things: for risk, right? What trimester may pose the least risk, and then in what trimester do we think maybe there's the most benefit for the baby? And I still think we're trying to figure those things out. One thing I do think is important to note, we didn't really touch on it too much, but you know, it has come up that in the first trimester, if women are taking the vaccine, we do recommend taking something like acetaminophen if they develop a fever to help reduce that, because we do know, you know, one piece of data we do know is that a high fever in early pregnancy can cause neural tube defects, can cause miscarriage. But I always contrast that with developing COVID in early pregnancy has a chance of, you know, giving you a much higher fever for a much longer duration of time. So again, that's why everything we talk about is that, you know, risk tolerance and risk benefit.
Absolutely. And I think you mentioned this, but the general consensus is the acetaminophen should be taken in the event that you develop a fever, not ahead of time, just for people who might be interested in knowing. I wanted to ask you all to share some of your favorite resources to use for information about COVID in pregnancy, or just COVID in general. Is there anything that you would, you can send it in the chat, or otherwise we'll be sending our participants a follow-up email, but any sources that you like? I'm going to send my own, which is, I think the Society for Maternal Fetal Medicine has created a really great resource, I think, for patients I don't know if it meets all of the criteria that, I mean, it's not a decision aid, but I do think it can be really helpful if people want information about what professional organizations are recommending. I think Dr. Morgan and Dr. Barker, you both said .gov, .edu, .org. .org, yeah, for the most part. Sometimes people can slide through a .org and not be reputable. So let's say .gov and .edu websites tend to be the reputable ones, like the CDC, American College of Obstetrics and Gynecology, Society for Fetal Medicine. Anything else?
I would just throw out there that people may be a little bit confused when they go to the website of our shared decision tool. So Dr. Lauren Westervart, who is one of the founding members of this group, she has a nationally recognized podcast as an emergency medicine doctor. So this is actually the website of her podcast. And because it had such a large national audience already, that's where we decided to house the vaccine tool. But she has an incredible amount of information about COVID in general, treatment in the ED, emerging therapies, what's worked, what's not worked. So you may go to the Foamcast site to get the tool, but dig around in there because there's a lot of really interesting information about of COVID and pregnancy. She was recently featured on the front page of the Boston Globe because in the work that she did with our group, she also, in the midst of it, discovered that she was pregnant. And so not only was she part of our group to make the decision, she also found out that she was pregnant in the middle of all of this as well. And that was the story sort of profiling her experience. But her website is a great resource.
And then I'd like to put in 2 plugs. One for the OBG project. So they're a group, they've put a lot of COVID information together, and I've included a link. And the other one is, I mean, I follow a lot of social media and I'm very careful about who I follow, but there's a physician, Dr. Jim Thornton, and he has put up a lot of information. It's primary sources. So every time a new article comes out about COVID-19 and pregnancy, it's up on his site. It's a lot to sift through, but if you're somebody who just kind of craves all that information, I think it's really helpful, and I'll include that one too.
Amazing, thank you. I want to sincerely thank all of our panelists who span multiple time zones, multiple states and countries even, for joining us today to talk about the very important subject of COVID-19 vaccination for pregnant patients. As a practicing OBGYN, I've received daily questions from patients, from friends and family members across the country about this, and I think it's been really difficult to weed through the information. And I hope that today's webinar will leave you with a basic understanding of the different COVID-19 vaccines available for pregnant people in the USA and their safety profile, tools for walking patients through the decision to get the vaccines, and communication tips that extend past talking about the COVID-19 vaccine. At June Motherhood, we recognize that what happens during prenatal care visits can be enhanced by evidence-based education and provided throughout pregnancy, and we're here to help you with it. So if you are interested in partnering with us to support your patients through their prenatal and postpartum journey, or if you're interested more about learning about June and how it might fit for your own journey, please let us know. And thank you for everyone helping in the back end, including Tina Balinson, Sophia Richter, and Catherine Mankiw. I hope you all have a great day, and panelists, thank you so much for your time. I know we managed to bring you all together, and your time is so precious, and your expertise that you've shared with us even more so. So have a great day. Thanks, everyone.